Okay, so let's get into it here. So the like I was saying, the presentation will be about 30 minutes long, and then I'll leave the rest open to questions. So I should be done around 7:05, 7:10. If you do have any questions, you can put them in the chat box, and I'll get to them at the end of the presentation. So my name is Dr. Ernesto Medina, founder of the Bay Area Health and Wellness Center. And we're here for the three secrets of hormone problems in men your doctor isn't going to tell you. All right. So let's jump right into it. Oh, give me 1 second here. Let me get this back up. All right, perfect. So the first concept I want to introduce to you guys is the concept of andropause. And of course, we're going to be focusing on men's health, but it's very informative and relative to women as well, because oftentimes the partner is the one who can identify some of these problems in the men without them actually realizing it. So let's get into it here. This concept of andropause. Now, the official definition is a syndrome associated with a decrease in sexual satisfaction or a decline in a feeling of general well-being with low T levels. Now, this whole idea of, or this whole definition of a loss of feeling of general well-being is something what I really want to focus on because it's very vague. And so what really is a feeling of not being well? And so the most common symptoms associated with andropause are going to be these top ones in white, which can be low sperm count and infertility, loss of libido or sex drive, balding, and increased fat around the belly and the hips. But the less common symptoms can be poor exercise recovery and loss of muscle tone. It can be loss of drive and motivation. And that's not necessarily sexual drive, but motivation in life and drive in life to accomplish tasks and things like that. And even depression can be a side effect of low testosterone in men. And then those of you who have attended any of my Alzheimer's and dementia workshops, you know that hormones, especially testosterone for men, when they're too low, can cause subtle memory issues and increases risk for dementia and Alzheimer's. For women, estrogen has the same effect. So estrogen is very important to the brain and protecting the brain. And after menopause, if estrogen levels are too low, they can have sudden onset of cognitive decline of dementia. Okay, so very important concepts here. Now, this picture makes me laugh because Homer Simpson is kind of a classic andropausal male with the big belly, lazy, and just an unmotivated person, right? By the character. And the other funny one I like is the character Al Bundy from Married with Children. And you can see there the receding hairline. You can see the belly starting to grow, the laziness, the unmotivation in life. Those are kind of your stereotypical andropausal males. Now, the struggle we have in the conventional healthcare model is really getting the proper lab testing done. The issue is asking your primary care doctors to order hormone levels is like pulling teeth. They most of the time they refuse to do it. If you bug them long enough, they will do it, but they only order a couple basic markers, and they don't order everything you're supposed to really see how healthy your hormone levels are. So I've had a lot of clients come to me frustrated because they ask their doctors to measure their hormone levels, both men and women, and they just refuse and refuse over and over again. The other big issue is identifying normal ranges of hormone levels. So any of those men who have asked, who have been lucky enough to get their testosterone measured, you'll notice on the lab, it'll tell you anything from, for example, 200 to 1000 is normal for testosterone. And so that range is so huge that if you test at, say, 201, you're going to be told your testosterone levels are normal and nothing's going to be proactively done to help improve that. Where realistically, we should strive to have our normal ranges in the upper, 85th percentile, in the upper end of normal to really be vital and healthy with those hormones. And the other big issue, which I think kind of unmotivates primary care doctors to order hormone markers, is that really the only solution they have to offer you is going to be hormone replacement or testosterone replacement. And there's a lot of negative thoughts, and there's some negative research again against prescribing testosterone replacement. So I think most primary care doctors just refuse to order them in the first place because either way, they're not going to prescribe you the testosterone replacement. So it's kind of a waste of their time. I think at least that's what my theory behind why they don't order them. So this is the real struggle that exists today in the conventional medical system. Now, what I want to do in this educational webinar is really teach you guys the story of hormones, how hormones work, how they're made, what their precursors are, and what you can do naturally without testosterone replacement to improve your hormone levels in a healthy way. All right, so secret number one I want to share with you guys is that all hormone production begins in the brain. And so I like to call this secret of neurological activation. Basically, the brain has to send a signal to the testes to activate. And it does that through a hormone called LH and FSH. Now, LH, when the testes receive the signal of LH from the brain, the testes make testosterone. When the testes receive the signal from the brain of FSH, they make the sperm. All right. So one of the biggest mechanisms that can cause low hormones or low testosterone is going to be lack of neurological activation, meaning the brain is not properly signaling to the testes, so we get no LH and FSH production, and so the testes just don't activate because they're not getting the signal from the brain. And over here to the left, you can see these are the primary causes and the primary drivers of no neurological activation. They are systemic inflammation, gut or digestive inflammation, which will eventually lead to systemic inflammation, the SAD diet, which stands for the Standard American Diet, high in carbohydrates and processed foods and high in sugar and processed fats, which will, of course, lead to both gut inflammation and systemic inflammation. We have chronic stress, and that can be stress, physical stress, it can be psychological or emotional stress, which all inevitably lead to inflammation as well. Now, the less recognized are going to be head injuries. So we have TBI, which is traumatic brain injuries. We have concussions and post-concussion syndromes, and to a lesser degree, whiplash car accidents. So a lot of people don't know this, but whiplash injuries that you experience in a car accident very often can cause mild concussion-like injuries to the brain. And this is a very big driving force of not only systemic inflammation, but neurological specific inflammation and chronic use of antidepressants. Now, antidepressants have long been known to cause loss of libido and loss of sex drive themselves, but they also change the chemistry of the brain, and not always for the best. Sometimes they're really focused on improving mood, But one of the biggest side effects a lot of antidepressants have is this killing of libido for men. Now, secret number two, or mechanism number two of possible causes of low testosterone is no testicular activation. Basically, what this means is the brain is properly signaling to the testes. So we're creating a good amount of LH and FSH, but the receptors of the testes are just not receiving the signal. Now, luckily, this is one of the more rare causes of low testosterone in men, but the primary causes of it can be direct trauma to the testes and autoimmunity. Now, it's labeled as rare. However, autoimmune issues are becoming more and more prevalent in the United States to the point where something like one in 7 people, I think, has an autoimmune disease today, and it's only getting worse. Now, just like men can develop autoimmunity to the testes, women can also develop autoimmunity to their ovaries. And one of the most hidden and complex drivers of infertility for both men and women can often be autoimmune issues. And I have yet to see a fertility clinic who actually tests for autoimmunity to the ovaries or autoimmunity to the testes in cases of low sperm production. And so it's not very well understood yet in the conventional medical system, but in our world, we always, if the other more common factors are not fixing the issue, we always test for autoimmune issues contributing. So that's a big one. Now, secret number 3 is going to be hormone overconversion. Now, what I mean by overconversion is a little complicated, so I'm going to break it down for you guys. This first line of hormones here, we have andro, testosterone, and DHT. Okay, these are the most common male testosterone and testosterone subtypes we have. The most important and most beneficial being testosterone itself, and the least beneficial being DHT. Okay? Now, all men and women make hormones by making andro first, then testosterone, and a little bit of DHT. Women will take this an extra step and convert their testosterone into estrogen, also known as estradiol. Now, this mechanism here can go both ways, meaning men, although men are supposed to stop at the testosterone hormone and not convert further into estrogen, they can, in certain cases, just like women, can overconvert estrogen into testosterone. So men can become estrogen dominant instead of testosterone dominant, and women can become testosterone dominant instead of estrogen dominant. Or I don't know if I said that twice. Men can also become estrogen dominant versus testosterone. And the primary driving factor of this is similar to the others we talked about before: systemic inflammation, gut or digestive system inflammation. So let me expand a little bit more on gut inflammation. Cases of chronic acid reflux, bloating, indigestion, chronic constipation, or things like IBS, irritable bowel syndrome, chronic diarrhea. All those things are signs of an unhealthy and inflamed digestive tract or gut. Okay? The standard American diet, like we discussed before, is a major contributor of both of those. And again, chronic stress in the form of physical, emotional, psychological eventually leads to inflammation as well. Okay, these are the primary drivers of this overconversion for men of testosterone into either estrogen or DHT. Now, let's let me explain a little bit more about DHT. Now, the reason DHT is unfavorable and even a little dangerous is because the place we have the most receptors for DHT are in hair follicles, so it can cause male pattern baldness, the prostate, so it can cause prostatitis or inflammation of the prostate, and inevitably can lead to prostate cancer. Okay, so this is why DHT is very unfavorable for us men. Now, if we overconvert into estrogen, so a male being estrogen dominant, we can get signs and symptoms of highly emotional, fat around the belly and the hips, and gynecomastia, also known as um, man boobs or breast tissue in men. Okay. Now, let's take, for example, a man who goes to a male health clinic. They test their testosterone levels, which is typically the only thing they test, and it comes back as, oh, your testosterone is low. Now, the doctor prescribes testosterone replacement to a man who's already overconverting their testosterone into DHT or estrogen. What would you guess is going to happen when you feed more testosterone, more synthetic testosterone into this system? That testosterone is going to temporarily spike up, but over time, it's going to continue over converting into DHT and estrogen because the primary driving factors, which we talked about here, of systemic inflammation, gut, the standard American diet, and chronic stress have not been addressed. And so this really creates a chronic, lifelong customer of these male health clinics because they're not properly testing and accounting for the other factors, which are largely diet and lifestyle factors. Okay. So I've had quite a few men come into my office that I've spoken with and met with, and they did testosterone replacement therapy because they were diagnosed with having andropause and low testosterone. They had all the symptoms. They did a course of testosterone replacement, and for about 3 to 6 months, they felt great. All their symptoms went away. And then after 6 months, guess what happened? All their symptoms started to come back because they were just over converting their testosterone. And what does the doctor end up doing? They'll remeasure testosterone levels. Maybe they've dropped down again because of the overconversion, and they feed more testosterone into the system, worsening all the symptoms over time. So that's a big problem, and this is why a lot of men fail on testosterone replacement therapy, or they just say it didn't work for them. It's just because the other risk factors were never addressed. Now, let's talk about the rest of the hormone story. So right down here, basically, we've talked about this already, that we had andro, testosterone, and DHT here, and estrogen. But what we didn't talk about is the precursors of those hormones. So if we start all the way at the top here, cholesterol is the basic building block of all hormones. So people who are on cholesterol medications, statin medications long term, and they have their cholesterol levels super low because their cardiologist wants it that way, guess what happens downstream? We can get disruption of all of our hormone production. Okay, so cholesterol is very important to measure on a blood test to make sure we have adequate amounts to even build hormones down the road. Now, cholesterol converts into pregnenolone, which is a hormone precursor, very important to brain and brain function. Pregnenolone converts into DHEA, here, another hormone precursor. Now, pregnenolone and DHEA are both available over the counter. So you can easily measure all of these, and if you find that maybe cholesterol is normal, but you're having decrease in pregnenolone or DHEA, you can synthetically feed these into the system to get downstream increase in hormones, right? So that's one of the ways you can support hormones naturally without testosterone replacement. Now, DHEA will convert either into progesterone, then into cortisol, or it'll come down into andro and come down this pathway of testosterone, DHT, and estradiol. Okay. So ideally, when you're working with hormones and with a doctor who's trying to improve your hormone-related symptoms, they really should be looking at all of these markers. So in summary, we have three main drivers of the hormone problems. Number one being no neurological activation, meaning the brain is not signaling out to the testes through LH and FSH, which again, LH and FSH should also be measured on a hormone profile, but they rarely do. Number two being no testicular activation, meaning the brain is signaling and is making LH and FSH. However, the testes are just not receiving the signal, and that can be either from direct trauma or autoimmunity causing disruption of that communication. And then the one we just talked about, hormone overconversion of testosterone into DHT or into estrogen. And again, we talked about the most common contributing factors being systemic inflammation, gut or digestive inflammation, the standard American diet, which very often contributes to both gut inflammation and systemic inflammation, chronic stress, again, either physical, emotional, or psychological stress, which inevitably leads to inflammation, systemic inflammation, traumatic brain injuries, concussions, and whiplash injuries. Okay, this is a big one that I see often in my office. A hormone disruption, especially with women, after experiencing some sort of head injury, either in a car accident or a sport incident in college or high school. And then antidepressant use. All right. Now, again, to really get a thorough understanding of what someone's hormones are doing and how they should be addressed and improved, you really have to measure as many of, if not all of these markers: cholesterol, pregnenolone, DHEA, progesterone and cortisol, andro, testosterone, DHT, and even estrogen. So for men, we especially want to order not just the male hormones, but the female hormones of progesterone and estrogen as well, right? Because remember, if you're converting all of your testosterone into estrogen and you put more synthetic testosterone into the system, you're going to end up making more estrogen in the long run. So we always want that tested to make sure that's not happening. And of course, you want to measure FSH and LH because they tell us if the brain is even signaling to the testes to produce testosterone in the first place. And then you want to measure blood sugar levels because blood sugar levels, either too high or too low, will contribute to inflammation, to systemic inflammation, but will also cause this overconversion of testosterone into estrogen. Now, this is one of the biggest side effects of diabetes type 2. Many people don't talk about this, but especially younger men who end up getting type 2 diabetes, one of the biggest side effects is loss of libido and sex drive because their blood sugar is so high. One, it creates chronic inflammation, but two, it is driving all their testosterone into estrogen. Okay, so big side effect of diabetes. And then lastly that we discussed was the autoimmunity. Um, Now, we don't typically screen for this right off the bat. Some indications it should be investigated into are going to be family history of autoimmune diseases or your own history of other autoimmune diseases, or you've maybe addressed all the other factors already and things are still not getting better. Then you should investigate into autoimmunity being a possible factor. All right. Perfect. So that's all the information I got for you guys. If anybody has any questions, feel free to type them into the chat box now. Give you guys about a minute or two. All right. All right, no questions coming in. Did you guys find this useful or informative? All right, we did get one question come in about blood tests. The question says, within your practice, are there specific blood tests that you order? The answer is yes. We order specific blood tests based on, basically what we do is we offer a free consultation, and based on kind of your history and the information you give me, we decide what tests we need to order. But for hormone panel specifically, say someone comes in with hormone complaint, we do look at all of these hormones here, as well as blood sugar levels, and as well as vitamin deficiencies. I've spent the last 2 years working and focusing on women and female hormones, and then realized I started getting a handful of men come in with their own hormone problems. And that's when I started to investigate further into it. And it turns out many men suffer from andropause and andropause like symptoms, and at an early age. It doesn't have to be, over 40 or over 50. I've had men at 32, 33 years old already diagnosed with andropause. And just like menopause, there's women who go through menopause late 20s, 30s, 40s. And it's not normal by any means, but it does happen. And it's because there's some other underlying issue going on. Now, the other question we have is exercise and diet enough to improve? That's a good question. I would say exercise and diet, if your hormone levels are already normal, exercise and diet is a great way to maintain them healthy. If you've been diagnosed with andropause already and you're having massive dysfunction, or you have a history of a head injury or a concussion, and that's causing your hormone problems, then exercise and diet are going to be super important. But targeted supplements are also going to be vitally important to try to balance out the issues that are going on that are underlying. Now, the other question we got is, what is the target age range for this therapy? Is it ever too late to test for this? That's a great question. And I would say no, it's never too late to test for this. I just started working with a 93-year-old man who came in for some minor memory loss, and he's worried about, dementia, Alzheimer's, and all that. Physically, he's very healthy, very active, still very sharp, but he's noticed that his short-term memory is not what it used to be. And it's recent, within the last, 3 to 6 months. So we definitely measured his testosterone levels, because remember I mentioned earlier, low testosterone for men can be a driving contributor of one, not feeling loss of well-being, but also of dementia. So at 93 years old, we definitely did measure his hormone levels, and they did come back low. So we're going to be um, using some of the strategies that we talked about in this webinar to improve that. Absolutely. Next question I have here: how much of hormone loss are due to age? That's a tough question to answer. I don't think any hormone loss. Well, I think they say something like 5 to 10 points per year after the age of 40 or something like that. But to be honest, just because that's common, it doesn't mean it's normal. Again, if you're an aging male and you're still consistently exercising, your strength training, your diet is good and clean, there's no reason why you have to have suboptimal hormone levels just because you're older. Like I said, I've seen 32-year-olds, 33-year-olds come in here with, the diagnosis of andropause and testosterone so low you could think they were 70 or 80 years old, but they're only 32. So I don't think there's necessarily a normal amount of loss of hormones due to age. Next question we have here. We're getting a lot of questions. Now, the next question says, you said there's a relationship to women also. Would a woman do a blood test for all the male markers and that would give you good feedback? Yes, great question. So even for women, we do test testosterone and DHT because, like I said, women can overconvert estrogen back into testosterone. Now, the most common side effect for women is going to be your polycystic ovarian syndromes. So cysts and fibroids, more specifically cysts that form on the ovaries and the uterus, which gets the diagnosis of polycystic ovarian syndrome, is very often caused from too much testosterone due to the same underlying risk factors we already discussed, which are right here: systemic inflammation, gut or digestive inflammation, the standard American diet of over processed carbs and too much sugars and sweets and carbohydrates, and chronic stress. So absolutely, we even for women we test the male hormones as well. All right, great number of questions. I'm gonna close off the webinar now, but what you're gonna get is you're gonna be rerouted to my calendar, and if anybody's interested in having a free 30-minute consultation, you can schedule directly from that link. I have a few hours Friday and Monday as well, and you can schedule that directly through the link. And we look forward to meeting with you. If you do decide to do the consultation and you have some old copies of hormone levels, you can bring those in. We can evaluate them, see how they look, see if they're optimal in the upper 85th percentile, and what other tests should really be looked at. All right. Well, thank you guys for your time. Hope you enjoyed the webinar, got some useful information out of it. Stay logged in so you can get the calendar link here.